Good morning. In continuation with our series of lectures on MDRO and antimicrobial therapy selection, I present to you Dr. Irfana, who is our ID consultant in BLK Max Super Specialty Hospital, and she'll be giving an ID perspective on the subject. So welcome, Dr. Irfana, and I hope all of you will enjoy this lecture. This will be a series of 3 lectures by Dr. Irfana. So enjoy and happy learning.
Hello everyone, I am Dr. Irfana. I am consultant infectious diseases. So we are going to discuss today an introduction to infectious diseases. So I have done my MBBS from Andhra Medical College and DNB Internal Medicine in Medanta, Gurugram, and then fellowship in infectious diseases from PD Hinduja Hospital, Mumbai. And right now I am working as a consultant infectious diseases at BLK Max Hospital, Delhi. So, as we are discussing the introduction to infectious diseases, so I'll discuss about fever. So, first, when we are seeing a patient of fever, we should decide whether the fever is due to infective origin or non-infective origin. Like some tumors, malignancies, drug reactions, there are many other causes of fever. So, immediately, whenever the patient comes to your OPD or IPD, just don't start antibiotic. We have to be rational with everything whatever we are doing. So if we take infective causes of fever, we'll discuss all these. So in infective, again, you have to decide whether this is viral, bacterial, fungal, protozoal, TB, what is the reason for the fever. And then if we take bacterial, even in bacterial, we have to further think that whether it is gram positive cocci or gram negative cocci, gram negative bacilli or anaerobes. So in gram-positive cocci, there are many gram-positive cocci like streptococci, staphylococci, um, enterococci, and cons is coagulase negative staph aureus. So here I will be discussing a little bit about coagulase negative staph aureus. Coagulase negative staph, we have staph epidermidis, staph saprophyticus, staph lugdunensis, and all these things. So whenever you get coagulase negative staph aureus, coagulase negative staph, you have to see from where it is coming. If it is coming in the blood culture, if it is coming only from single blood culture, then you think whether it is skin contaminant. If it is coming from paired blood culture, then you have to look for other source of infections, like is the patient having any prosthetic valve or any prosthetic joint, all these things. So that's why you have to send paired blood cultures always, so that you rule out the contamination. So coagulase negative staph aureus is mostly a contaminant. If it is growing in single blood culture, then you can just remove the central line if it is coming from a central line. One important thing about coagulase negative staph aureus is that staph lugdunensis is cons, but it has a severe, like it has virulence similar to staph aureus. So you cannot ignore staph lugdunensis and treat it like we treat staph aureus. And coming to gram negative cocci like Neisseria gonorrhoeae, Neisseria meningitidis, we encounter them sometimes in our practice, but more common which we see in our ICUs and in IPDs are gram negative bacilli. So even gram negative bacilli, it is divided into Enterobacteriaceae and non-Enterobacteriaceae. Enterobacteriaceae, you have E. coli and Klebsiella, and rest others like Pseudomonas, Acinetobacter does not come under Enterobacteriaceae. They are non-Enterobacteriaceae. And anaerobes, you have Bacteroides, and all these anaerobic organisms. So always you have to think what is the most possible bug here, and then choose the drug combination as per the bug. So second thing is that we have to know whether we are giving empiric treatment or deducted treatment. Empiric treatment is that you have not got the culture report and you know that the patient is sick, septic, and you have to give some antibiotic or antifungal. That's where you have to think all these things and then choose the empiric antibiotic. Empiric antibiotic does not mean that you give some random antibiotic to the patient. You have to have some rationale, which is the organ involved, organism, most possible organism, most appropriate drug of choice in that particular scenario. Coming to directed is depending on the culture and sensitivity report. You choose the drug of choice for that particular situation. And then coming to BYC is budding yeast cells. If you have most in the ICUs, we send sputum and ball cultures, and the lab reports it as BYC in sputum or ball, budding yeast cell. Budding yeast cell usually we encounter candida, but usually candida does not cause pneumonia in normal patients or in normal ICU patients also, but it causes pneumonia in extremely sick patients, extremely run down and extremely immunocompromised patients. So even in normal ICU patients, if you get budding yeast cells in the bowel or sputum, you don't need to treat it. It is a normal oral flora. Then if you see budding yeast cells, it is not just candida. It can be cryptococcus, it can be trichosporon. So you have to have this in the background that BYC doesn't just mean candida. And then coming to mucositis, you see mucositis in a lot of hematopoietic patients who have malignancies, AML, ALL, and post-transplant also due to chemotherapy and neutropenia. All these patients have mucositis. So when there is mucositis, there is tendency for the local flora to get into the bloodstream, translocation of bacteria into the bloodstream from oral as well as the gut. So in these situations, you have to think of anaerobes as well as gram-negative bacilli, enterococcus. They can come from the gut into the bloodstream directly. And candida is also a flora of the our gut, upper GI, and as well as oral cavity. So it can invade and cause invasive candidiasis. That's why we have to give antifungal prophylaxis in mucositis patients like fluconazole prophylaxis. And you have to have that background of GNB and enterococcus coming from the gut. So how to draw blood cultures? This is very extremely important. So what is the set? What is the pair? Is there any difference? So set is one aerobic plus one anaerobic is called a set of blood culture. You have to always have two bottles. One is aerobic bottle and anaerobic bottle. Both are different. You have to get it from the lab and send both aerobic and anaerobic blood cultures for all patients. And coming to pair is two blood cultures from two different sides, like left hand and right hand. If the patient doesn't have a central line, if the patient has central line or femoral line, any other line, then you send one from the central line and one from the periphery. So what is the importance of paired blood culture? One is that you rule out contamination, because if the same bug is growing from both central and peripheral line with differential time to positivity of more than 2 hours, DTP, it means that the bacteria or the fungus is coming from the central line. The source is the central line and then it is going into the blood. If the DTP is less than 2 hours and it is both the blood cultures, blood samples are growing at the same time, almost 10 a.m. and it is also 10 a.m. like that, then it means that it is an intrinsic bloodstream infection. We don't need to remove the central line in that situation. But when there is DTP positive and we know that the source is the central line, then definitely we need to remove the central line to have a good source control. So you have to always see for DTP. And then paired blood cultures are also important. As we can see in my next slide, that the more blood cultures you take, the sensitivity will be more. And paired blood cultures we have discussed, and then CLABSI and CRBSI. So what is difference between CLABSI and CRBSI? CLABSI is central line associated bloodstream infection, and CRBSI is catheter related bloodstream infection. So CLABSI is a surveillance definition, and for CLABSI we just need a blood culture positivity from central line. That's it. We don't see any clinical criteria. We don't see what the other blood culture or the peripheral blood culture is growing. It just means that the central line is growing some bacteria. So this is just for surveillance purpose. But when you are saying CRBSI, it means it is a clinical definition with two blood cultures positive with one central line growing the bacteria much earlier than the peripheral blood culture, and the patient will have some clinical symptoms as well. So this is a best practice for blood culture. So the volume of blood culture is also very important. You have to take minimum 20 ml for adult patients, 10 ml in aerobic bottle and 10 ml in anaerobic bottle. So if one blood culture we are taking only single blood culture, the sensitivity is very less, around 50 to 70%. The more blood we are taking, 40 ml of blood culture, it gives around 89% sensitivity, and 60 ml, 3 pairs of blood culture, 3 sets of blood culture gives around 98% sensitivity. That's why the more you take the blood cultures, the more is the sensitivity. This is very important in endocarditis patients as well. So now we will discuss about the culture methods. How do we identify bacteria in the microbiology lab? So initially we take the blood culture, we put it in the automated system. Yeah, this is the automated system where we have an alarm for every blood culture positivity. So this beeps, and then you can go and see in the system whether any blood culture has flagged positive. Flagging positive means that the color of this light will change. It will be red or green. Depending on that, you have to see whether the culture is flagged positive or not. Then after this culture has flagged positive, we have different methods to identify the bug and do the sensitivity testing. So first one is Vitek2, second is Malditoff, third is the BCID2. So we'll discuss each thing in detail. So this is the blood agar plate where there is growth of colonies of bacteria. So you take a toothpick and sterile toothpick and streak it into the test tube. This is a test tube, and see the density with a densitometer and standardize it, and then you put a Vitek card depending on the type of bacteria, depending on the gram stain, and then you put the card and this gives the identification and the susceptibility. This is Vitek2. And second one is Malditoff. Malditoff is matrix associated laser desorption ionization time of flight mass spectrometer. So the Malditoff is a very advanced method of identification of organisms. So here these are the wells. It has many wells. So many single card or cassette will have many wells with which can accommodate these many patient samples, as you can see here. So here this is a blood agar plate with colonies, and you take this and this smear it onto each well, and then you put this into the Malditoff machine, and it gives the susceptibility. It gives the identification. It compares the PCR or the genetic material with the database in the background, and then it gives the percentage concordance like 95 to 97%, like that, and that's how you identify the organism. Sometimes Vitek2 can misidentify some organisms like Burkholderia as Acinetobacter or Pseudomonas, and you can confirm it with Malditoff. Next, how do we read a culture report? So here, if you see, this is Staph aureus as is written here. So first, whenever there is a report of Staph aureus, you have to decide whether this is MSSA or MRSA. MSSA means methicillin sensitive Staph aureus and MRSA is methicillin resistant Staph aureus. If you see this report, there is no methicillin. So how are we going to read this? So we have to see oxacillin. So if it is oxacillin sensitive, it is MSSA and oxacillin resistance is MRSA. So how does it matter if it is MSSA or MRSA? So the choice of antibiotic is different for both MSSA and MRSA. So for MSSA, don't give vancomycin. You have to give IV cloxacillin or flucloxacillin 2 gram 6 hourly or cefazolin 2 gram TDS. If it is MRSA, then you give either Vanc or Teicoplanin. So if the patient is having osteomyelitis or endocarditis with MSSA, you need long duration of treatment of 6 to 8 weeks. Then initial 2 to 3 weeks you can give IV, then followed by oral flucloxacillin or cefalexin. Then MRSA, you all know the drug of choice is vancomycin, or if it is vancomycin resistance, then you give teicoplanin or daptomycin. So for MRSA, we don't have many oral options available. So only one oral option available is right now linezolid. So linezolid, the side effects of long-term use of linezolid are severe peripheral neuropathy, cytopenias, pancytopenia, lactic acidosis, hyperpigmentation of the tongue. So you have to frequently monitor CBC if you are giving the patient linezolid. And mind you, linezolid, the dose of linezolid is 600 milligram twice daily for bacterial infections. But when you are giving it for TB, a second line drug, or for NTM, non-tuberculous mycobacteria, the dose of linezolid is just 600 milligram once daily, not twice daily. So next we'll see this urine culture report. So we have to identify which type of bug is this, whether this is ESBL, CRE, CRO. So here you can see that this is resistant to ceftriaxone but sensitive to piperacillin tazobactam. This is how an ESBL report will look like. So this is ESBL, E. coli. The definition of ESBL is that the organism should be resistant to third generation cephalosporins and sensitive to BLBLI, beta-lactam inhibitor, and aztreonam, the mechanism being hydrolysis. So here it is resistant to third generation cephalosporin but susceptible to beta-lactam inhibitor. So this is a typical ESBL organism. So in ESBL, what is important is that if it is coming from urine or from pus, you can take it at face value and give piperacillin tazobactam or cephalosporin sulbactam as treatment. But if the same bug is growing in blood culture, then you have to choose drug of choice as carbapenem, because you have to go back to Merino trial and read there that the BLBLS are compared to carbapenems in the trial, and it was shown that the carbapenem decreases the mortality rate when compared to giving BLBLI to a patient with positive blood culture. But even if the patient has lot of pus somewhere, BLBLS have inoculum effect, so they may not be able to work properly. In that scenario also, we need to give carbapenems, and we have to aim for a good source control. So this is regarding ESBL. So there are different kinds of organisms. So beta-lactam, in beta-lactam antibiotics, we have penicillins, cephalosporins, carbapenems. All these things come under beta-lactam. Beta-lactam inhibitors, we know that there are sulbactam, tazobactam, clavulanate, all those things come under beta-lactam inhibitors. So beta-lactam antibiotics contain a beta-lactam ring and which gets destroyed by the enzymes beta-lactamases which are produced by the bacteria. And this beta-lactam inhibitors, they inhibit the beta-lactamases. So this is a mechanism. When it comes to ESBL, we have already discussed, and CRE is carbapenem resistant enterobacteriaceae. CRO is carbapenem resistant organism. So in CRE only Klebsiella and E. coli comes. In CRO, it includes everything like pseudo acinetobacter and even E. coli and Klebsiella. So coming to Calzavi astronum. So we are hearing it recently day in and day out that ceftazidime avibactam is the new kid in the block. So when do we choose ceftazidime avibactam? When do we choose colistin or polymyxin? So in the head-on trials which were done comparing colistin and zavicefta so zaviazone was associated with less mortality when compared to colistin. But why can't we give zavicefta for each and every patient? Like in all the ICU patients who are critically ill, we can go ahead with zavicefta, right? But we can't because zavicefta is not sensitive. Like we can't give it for Acinetobacter because it will not work for Acinetobacter. And also recently, it was seen that E. coli has PBP3 inserts, penicillin binding protein 3 inserts, which has caused resistance to ceftazidime avibactam and astrinum. So that's why we have to see something more to decide whether we can use this combination or not. So that's why whenever you see a patient with carbapenem resistant organism like E. coli, Klebsiella, Pseudomonas, you can send Carba expert or expert Carba or panel for carbapenemase resistance. So here you can see carbapenem resistance detected or not, the isolatives of Klebsiella pneumoniae from blood. And these are the 5 enzymes, carbapenemases. These are the enzymes which can be detected by Carba R, IMP, VIM, NDM, KPC, OXA48. And here NDM has been detected. So KPC is mostly seen in United States, Western countries. It is not our problem right now, but our problem is NDM and OXA48, and sometimes IMVIM also comes in Pseudomonas. So the significance of this report is that if the patient is only, if the isolate is only OXA48 positive without NDM, then we can just get away with ceftazidime avibactam. There is no need to give astrinum. If the patient is NDM positive, on the other hand, we have to give both in combination, ceftazidime avibactam plus astrinum. This is what you have to remember. And if the patient is having NDM, it doesn't mean that the combination will work. So you have to do something more. So this is what is called synergy. So what is synergy testing? We give both antibiotics in combination and see whether the MIC has decreased or not. So these are the methods recommended by ICMR for synergy testing of Calzavi. So this is the ceftazidime avibactam disc. This is the astrinum disc. So they recommended that you put the astrinum disc, remove, not disc, strip. This is a strip method, strip stacking method. So initially you put astrinum strip, then remove it after 10 minutes. Then you put ceftazidime avibactam strip, and then on top of it again you put the astrinum strip. Then you see the zone of clearance here, and you see the MIC here, and it gives a clearance, and this is susceptible. That means synergy is positive. Here, this is a strip cross method, and you see the zone of clearance here. Next, this is also synergy testing, but this is strip disc method. This is the strip, and this is the astronome disc. Sometimes you don't get strips, and then you are forced to use astronome disc, and you see the diameter, zone diameter. So this is inverted D-shaped clearance. So here the astronome is resistance. So the zone diameter is very less. You have to measure it. It is very less. Here astronome zone diameter you have to see and see whether this is resistant or sensitive. Here cephalosporin avibactam is not giving any zone. This is just the astronome. So there is no synergy, but astronome is susceptible. But the combination is not synergistic. But here you can see given the cephalosporin avibactam is giving some clearance. Here it is giving some clearance. So this is synergy positive. Sorry. So next we'll discuss about the, going back to the last slide. So first, whenever there is a CRE positive patient, the protocol is that except for Acinetobacter you don't need to send Carba expert, but for other CROs you can send Carba R and then decide whether it is NDM or OXA48. If it is OXA48, only give ceftazidime avibactam. If it is NDM, you have to give astronome also in combination, but you have to see whether the synergy is positive or negative. Only if the synergy is positive, you can give ceftazidime avibactam plus astronome. If there is no synergy, then you have to look for some alternatives like colistin plus some other combination regimen like tigecycline, meropenem, all these things. If the meropenem MIC is more than 16, then you can't either use meropenem. So this is about carbon resistant organisms, and it is recommended by many that we should not use ceftazidime avibactam as a empiric therapy without having any culture report, because it is the only drug which is available right now which seems to work little bit, that is ceftazidime avibactam and astronome. So we have to reserve it for very sick patients, and we have to give it rationally depending upon the all these molecular tests, so that it doesn't get resistance, and we have to make sure that it doesn't get resistance very early like other antibiotics because of the irrational misuse. So we'll go to BCID2 panel. BCID is blood culture identification panel. So the importance or the significance is that it decreases the time to positivity. Like if going back to the previous slides, you can see that the automated system has given an alarm when the blood culture has flagged positive, and then from that blood culture bottle you take it and then you can directly do the BCID2. You can put it into the BCID machine and you'll get report within 2 hours. So this is extremely important in critically ill patients and hematopoietic stem cell transplant patients, profoundly neutropenic patients, because they don't give time. Because we use empiric antibiotics without having any sensitivity and identification of the organism. So sometimes we give high-end antibiotics, sometimes we give low-end antibiotics which don't cover that particular bug. So when you have the BCID panel in your hand, you are getting the blood culture report within, or the BCID report within 2 hours of blood culture flagging positive. So it is saving 24 to 48 hours of your time compared to when you do it with Vitek 2 or Malditoff. So for stewardship point of view also, it is very important because you are giving targeted therapy here. And then anyway you are going to send the blood, you are sending the blood culture. From that blood culture bottle only you have taken this blood. So that blood culture ultimately will grow after 24 to 48 hours. Give the report or depending on traditional methods. So you compare both of these and then you can change if there is any little bit 5% change in the report. You can change depending upon the final blood culture report. But this is like extremely sensitive test and has huge number of organisms in the panel. So there is around 90 to 95% concordance rate between the final blood culture and BCID2 panel. So it is extremely useful. It could be little expensive, maybe 20 to 40,000 depending upon the institute. But if you see per day cost of antibiotics for a given patient in the ICU, maybe there will be 1, 2 to 3 antibiotics. So the ultimate cost of antibiotics per day is around 20 to 40,000 for some patients. If it is antifungal, it is more expensive even. Then if you compare that, you are giving the antibiotic for 3 to 4 days or many more days. If you compare it with the cost of BCID2 panel, it seems to be more worthy. So here the organisms which are covered are gram-positive bacteria, Enterococcus, Listeria, Staph, Epidermidis aureus, Streptococcus, gram-negative bacteria, Acinetobacter, Enterobacteriales, E. coli, Klebsiella, and Serratia, Salmonella, Haemophilus, Neisseria, Pseudomonas, Stenotropomonas, and in East, Candida albicans, auris, and other species of Candida. So this is an example I have just put here so that you see what all are covered under BCID2 panel. So BCID2, one more advantage of BCID2 is that it also detects the resistance genes, so that it will tell you whether the patient is having CRE or ESBL or colistin resistance, so that you choose a directed antibiotic depending on the bug, also the sensitivity. So here, if you can see, this is CTXM. CTXM is, it means that is an ESBL. CTXM comes under class 1 in the Ambler classification. This is IMP not detected. This is a carbapenemase. KPC is Klebsiella pneumonia carbapenemase not detected. MCR, this is for colistin resistance. This is not detected. That means there is no colistin resistance. These two carbapenemases are not there. ESBL CTXM is not detected. MAK and C are for MRSA. So MAK is not detected means there is no MRSA. So NDM not detected. OXA48 is also not detected. Van-A, Van-B is for vancomycin resistance. So you get these many genetic gene information also, so that you decide on the antibiotic. Then you can adjust depending upon the final blood culture report. Next, coming to ceftriaxone, sulbactam, EDTA, and meropenem sulbactam. These are the fixed drug combinations which we are encountering in our day-to-day practice. So the issue with ceftriaxone, sulbactam, EDTA, Iloris, is that the EDTA concentration in the drug which you are giving is very less, and the EDTA concentration is a disc provided by the pharmaceuticals is very high. That much of EDTA can't be put into the drug, and if it goes into the system, it is extremely toxic. The dose of EDTA which needs to be given for it to act is to the extent of lead toxicity. Whatever the drug, whatever the EDTA you have to give in a patient with lead toxicity, that much of EDTA you will require for it to act if you have to give ceftriaxone, sulbactam, EDTA. Basically, EDTA chelates the ion, zinc ion, and That's how it is useful in resistant organisms, but that much of concentration is not there in the drug which we are giving, but that concentration is there in the disc which they are providing. That's why this combination will show as sensitive in the sensitivity report. If you see, even if carbapenem resistant organisms also, sometimes you can see that the ceftriaxone sulbactam EDTA, it is coming sensitive in the report in vitro, but it will not translate, it may not translate into in vivo because of the EDTA concentration. And coming to meropenem sulbactam, this is one more irrational combination which we are coming across. So sulbactam, this is a beta lactam inhibitor. Meropenem we are using for ESBL organism if it is there in blood culture. So meropenem is already covering the ESBL. So what is the additional benefit of sulbactam? That's what we have to think. And if you are adding sulbactam, what is the added benefit you are giving for the patient? If you think of Acinetobacter, maybe we are giving the sulbactam for Acinetobacter. The dose of sulbactam which needs to be given in Acinetobacter is 9 to 12 grams per day, which is the required dose for Acinetobacter in a patient with normal creatinine. But here meropenem sulbactam contains 500 milligrams. So if you are giving the TDS dosing, so you are giving 1500 milligrams of sulbactam per day. So there is a huge difference between 1500 milligram per day and 9 to 12 milligram per day. So maybe we are increasing the resistance to sulbactam for Acinetobacter by using this combination. This is what we have to think. But there are some studies where they have seen there is synergy between meropenem sulbactam when given for Acinetobacter. It prevents Acinetobacter or treats Acinetobacter, but whatever studies are there, there are in vitro studies and there are no in vivo studies which are available to see that this combination is beneficial for Acinetobacter. And in vitro studies also, the dose of sulbactam there will be much higher, but here the dose of sulbactam in the drug combination is 1500 mg per day only. So we have to think of using these irrational fixed drug combinations and then take a call whether we need to go ahead or not. So moving on, we'll discuss about COTI, that is catheter associated urinary tract infection. So if the patient is having a Foley's catheter for quite some time, 20-30 days, and suddenly the patient is spiking fever in ICU, the impulse is that you send the urine culture from the Foley's catheter, that Foley's catheter. But you know, the Foley's is for there in situ for such a long time that it gets colonized by some of the other bacteria or fungi and gives false positive report. So if the patient is having long-term Foley's catheter and if you have to send the urine culture, make sure that you change the Foley's catheter and then send a fresh urine routine and culture and treat accordingly. Don't send cultures from an old catheter and treat that report. So whenever you are seeing an urine culture report, you always have to make sure whether it is a new Foley's or very old Foley's catheter. Second, we'll discuss about lower urinary tract, upper urinary tract infection, pyelonephritis. So if you have a patient with urinary tract infection, you need to first decide whether it is just cystitis, it is coming from the lower urinary tract, or it is pyelonephritis. So you can examine the patient clinically. You can examine for renal angle tenderness for all patients or urinary tract infection. Just have to punch in the back in the renal angle for the patient and see whether he is tender. Then you have decided that there is some infection in the kidney. If there is infection in the kidney, then you have to decide whether there is any pus collection, whether it is drainable. or is it emphysematous pyelonephritis, where there is gas formation, which can be due to anaerobes or Klebsiella or E. coli. So, you all patients of UTI, you have to see all these things, and if feasible, we should do drainage of the pus for good source control, along with the required antimicrobials. And if it is not feasible and the kidney is grossly infected, sometimes you have to do a partial or complete nephrectomy for the benefit of the patient. And next, coming to drain culture. So if there is an old drain post surgery or post pancreatitis or gallbladder malignancies, many other conditions, hepatobiliary system issues, sometimes there are drains for the patients. And if you're sending a drain culture, make sure that the drain is just less than 24-hour old. If you are sending cultures from drains which are there for 4 or 5 days or much more, you tend to get contaminants, you tend to get colonizers. So that drain fluid is going to grow some bacteria, some or the other fungi. It is not a true pathogen. It could be a contaminant. So better to change the drain or send it within 24 hours or do a direct aspiration to send the culture. Don't send cultures from an old drain. Other point, next point is that probiotics in immunosuppressed. So we are using probiotics, Visilac, Enterogemina, all these things day in and day out in ICU patients predominantly. So before prescribing probiotics for any patient, make sure that they are not extremely immunosuppressed, extremely neutropenic. So in these immunosuppressed patients, the lactobacillus or the viable organisms, viable fungi which are there in the probiotic, they invade into the bloodstream and they can cause invasive fungal infections. Sometimes Saccharomyces also grows in blood cultures if you give probiotic to an immunosuppressed patient. Other thing is that duration of antibiotic or antifungal. So for antibiotics, the duration depends upon the situation. Like, is it just a cystitis? Is it pyelonephritis? Is it abscess formation? So the duration is different for different situations. So for cystitis, only 5 to 7 days of antibiotic is enough. For pyelonephritis, sometimes you have to give 2 to 4 weeks, and if there is pus formation, then minimum 4 weeks. Empyema, minimum 4 to 6 weeks. And for antifungals, it depends whether it is candida or mold infections, which we are going to discuss in our next lecture. And how to de-escalate, that is also very important. So if you are giving some IV antibiotic and the patient is being discharged home, you just don't give any random antibiotic. You are just writing cefuroxime, you are just writing fluconazole. It is not the way. You have to go back to the previous culture report and see what is the bug, what is the drug of choice, what is the sensitivity. If this report does not have any sensitive antibiotic, sensitive oral option, then you have to counsel the patient to give whatever sensitive intravenous antibiotic is there. You just don't convert IV to oral without any rationale. You have to see if whether the patient is having any oral option available. Sometimes you have candida growing from cultures, blood culture. It is resistant to fluconazole and oriconazole, and it is only sensitive to echinocandins and amphotericin. Then there is no option to give, there is no oral option to give. Then you have to discharge the patient on IV echinocandin. You have to counsel properly, and there is no other way. Then line removal. If there is a central line growing growing some bacteria, it is a CRBSI with documented DTP with clinical features and everything. Always try to see whether you can remove the line for source control, especially if the patient is hemodynamically unstable and the patient is having virulent organisms like staph aureus, candida, these things growing from the blood culture, from the line. Definitely try to remove the line as soon as possible, because early source control is a must. Otherwise, the patient will land up in sepsis, septic shock, or may have embolic phenomena and may cause endocarditis and death. And other thing is that head to toe examination is important for each and every patient. You get many clues in the head to toe examination. That's why you say history and clinical examination gives 60 to 70%, or maybe sometimes 90% of your diagnosis is there. So if you see this patient, this is a neutropenic patient, I think AML patient with nodules in the skin. This is a nodule, and this is uh, redness here with pus and blackening. So these kind of nodules are seen in patients. It could be of any reason. It could be fungal like candida, and mold infections like mucor, aspergillosis, like thyma gangrenosum. So you have to take a punch biopsy, superficial skin biopsy, and send it for histopathology and bacterial and fungal cultures for each and every patient, and see whether it is infective, non-infective. If it is infective, whether it is bacterial, fungal. If it is fungal, then whether it is mucor, aspergillus. So that's how the approach should be. Here you can take this pus, and I think this was ecthyma gangrenosum in a patient, and it has grown pseudomonas, and we have treated the patient. So thank you for the patient listening. I hope you have enjoyed the lecture. So my next lecture would be a talk on fungal infections, introduction to fungal infections, how to manage fungal infections. So looking forward to join, for all of you to join. Thank you so much.